Orientation is locked. Rotate device back. Okay, I don't know how to do that, so let me just do what I was doing here. I'm so sorry for persons who were on the live earlier. Probably got kicked off. All right. Simone, welcome, welcome, welcome. Yeah, welcome everybody. Destined for greatness. Welcome. All right. So let's start the questions. So as I say, we're doing a musculoskeletal system tonight, and we'll be looking at different areas of the exam. All right, we'll be looking at management of care, safety and infection control, psychosocial integrity, basic comfort and care, and those are the different areas, and some pharmacology questions as well. So hopefully we're able to cover all of that. I know it might be, might not cover all of that in 2 hours, but let's just see how much we can do. All right, so the first question, as I say, A, B, C, or D, choose whichever one. And then from there, we will go ahead and try to discuss. All right. So the first question, a 72-year-old with a severe osteoarthritis is scheduled for total knee arthroplasty. Which preoperative action should the nurse prioritize? So a 72-year-old with severe osteoarthritis is scheduled for total knee arthroplasty. Which preoperative action should the nurse prioritize? A, teach isometric quad exercises. B, confirm the presence of advanced directives. C, obtain baseline hemoglobin and coagulation studies. D, instruct on post-operative CPM machine use. Oh, what was CPM again? What is CPM? Hold on there. C, Carousel says C. Obtain baseline hemoglobin and coagulation study. Let me see what CPM is. CPM. Continuous passive motion. So CPM is continuous passive motion machine. It gently moves a joint through its range of motion, most commonly after knee replacement surgery and other orthopedic procedures like the hip and elbow surgeries. All right, so you have a 72-year-old with severe osteoarthritis that is scheduled for total knee arthroplasty. Which preoperative action should the nurse prioritize? A, teach isometric quad exercises. B, confirm the presence of advanced directives. C, obtain baseline hemoglobin and coagulation studies. And D, instruct on post-operative CPM, which is continuous passive motion machine use. And Carousel says C. All right, and the answer is actually C, to obtain baseline hemoglobin and coagulation studies. All right, so when you're thinking about your pre-op, you definitely want to get your blood work. And you want to look at your hemoglobin coagulation because you want to plan for, if in the event that the patient needs any blood, you know what to do. Or in the event that, the patient is bleeding too much, you know what's happening. So definitely you want to get your blood work, your basic hemoglobin and coagulation studies there. Teaching the patient different exercises is very good, but look at the word, it says prioritize. Which one of them is most important? So all of these are important for the patient, but what is it that you're going to be prioritizing preoperatively for this patient? All right, so major orthopedic surgery, risk bleeding, so you need a baseline H&H and coagulation to inform perioperative management and transfusion planning. All right, so most of the time you're always going to make sure you get a blood transfusion consent to go ready for the patient. You get your your regular pre-op paperwork signed up. All right, and then from there you get your blood work as well. All right, so C, you definitely want your baseline hemoglobin and your coagulation studies. All right. Number 2, a patient on long-term corticosteroids for polymyalgia rheumatica is admitted for a hip fracture. Which care coordination issue is most important to communicate to the surgical team? So you have a patient on long-term corticosteroids for polymyalgia rheumatica. that is admitted for hip fracture. Which care coordination issue is most important to coordinate which are coordination issue is most important to communicate to the surgical team? A, need for physical therapy post-op. B, risk for adrenal suppression and preoperative steroid stress dose. C, long-term history of muscle weakness. Or D, insurance coverage for surgery. So you have a patient that is on long-term corticosteroids. Which one? Okay, Carousel says B. Okay, risk for adrenal suppression and perioperative steroid stress dose. All right, so chronic steroids cause HPA, axis of suppression. Perioperative steroid coverage reduces the risk of adrenal crisis. Hi, Holy File. Welcome, welcome, welcome. How are you doing? All right, so B is the answer, okay? Yes. Chevenez Price, welcome, welcome. All right. Hold on 1 minute. All right. So what we were looking at, polymyalgia rheumatical. Let's just read on that just a little bit. All right. All right, so that is a condition that causes muscle pain and stiffness primarily in the shoulders, the hip, and the neck. All right, and anytime you see poly, you know that it's more than one. Myalgia is usually related to pain, rheumatical, inflammation. It is a type of inflammatory arthritis, particularly in the shoulders. It is a type of inflammatory arthritis. The cause is unknown, but it is believed to be an autoimmune disorder where the body's immune system mistakenly attacks healthy cells, all right, or tissues. So if you have a patient that is on long-term corticosteroids for polymyalgia rheumatical, all right, which care coordination issue is most important to communicate to the surgical team, and that is the risk of adrenal suppression and perioperative steroid stress dose, all right? And it says that chronic steroids cause HPA, axis suppression. Perioperative steroid coverage reduces the risk of adrenal crisis. All right. A nurse is managing a unit must assign a post-op total knee replacement patient who is on PCA and high fall risk. Which nurse is best? So say you have a nurse managing a unit that must assign a post-op total knee replacement patient who is on PCA and high fall risk. Which nurse is best? A new graduate, which is A, floated from med-surg with 1 month orientation. B, experienced ortho nurse, floated in the last week. C, float nurse from pediatrics with 10 years experience. D, agency nurse with prior ortho experience but unfamiliar with PCA policy. So who would you give that patient to? So you have a nurse that is managing a unit and they must assign a patient that just had a post-op total knee replacement, which is on PCA, and the patient is also a high fall risk. Which nurse is best suitable for that patient? Is it A, new graduate, floated from a med-surg unit with 1 month orientation? B, is it the experienced orthopedic nurse floated in the last week? C, the float nurse from pediatrics with 10 years experience. D, an agency nurse with prior ortho experience but unfamiliar with PCA policy. Who would you assign that patient to? A, B, C, or D? Carousel says B, the experienced ortho nurse floated in the last week. Do we have anybody else on YT here with anything else? Thank you, Jones, for coming back. Marlene, thank you for that follow. Okay, so it's actually B. All right, experienced orthopedic nurse was floated on the unit. All right, so somebody that is pretty new in terms of orientation, they don't want to give that patient that post-op patient. So the new graduate who floated from the med surg with 1 month experience is a no-no. So always use a process of elimination and see if we can try to, remove who is not suitable from that scenario. The float nurse from pediatrics with 10 years of experience might not be, familiar with patients with total knee replacement. So you want to give her that person. And then it's a float nurse. Always try to use your full-time staff or persons who have been working in that area for a while. A float nurse is not going to know much about the patient population on that unit. Agency nurse is going to be the same thing. That person has a prior orthopedic experience, but they're unfamiliar with the PCA policy, because remember, these are agency nurses, so they're not always there and probably, up to date with the policies of the hospital. So always try and use somebody that has experience, who works there full time in that unit. So the experienced orthopedic nurse was floated there in the last week. That would be the most suitable person for that patient. So recent oriented experience, orthopedic nurse is safest for high-risk post-op patient. And as we say, you always use safety to answer your question. So just think about the safety of that patient. Do you think a new graduate would be the best suitable for? Because that person probably will mess up their license as well as with the patient. You understand? So that person is not going to be the best person. And even if you look at the safety of both person, give that person the patient. All right. So always go with whoever is going to be considered safe for the patient. All right. A patient with MRSA osteomyelitis needs urgent debridement or debridement. The nurse should place the patient in. So you have a patient that has MRSA osteomyelitis and needs urgent debridement or debridement. The nurse should place the patient in A, standard precautions only, B, airborne isolation, C, contact precautions plus private room, or D, droplet precautions. So you have a MRSA patient. What kind of precaution would you use for that patient? So you have a patient that has MRSA osteomyelitis that needs urgent debridement, all right, cut down of the wound there. The nurse should place the patient in A, standard precautions only, B, airborne isolation, C, contact precautions plus a private room, or D, droplet precautions. Thank you so much for tuning in. TS Music Entertainment. Shayna, thank you for joining. All right, Marlene says C, contact precautions plus private room. Definitely. You will go ahead and make sure that patient is in a private room, because you want to prevent any form of, exposure. All right, when you're doing the cut down. So when you're thinking about a patient that has MRSA, you want to make sure you have on, your different PPEs, your glove, your gown, things like that. All right. And it's contact precautions. So MRSA requires contact precautions to prevent transmission via the surfaces and hands. All right. And as we say, anytime you see an answer that says only, stay away from that question. All right. So where it says standard precautions only, no. You'll eliminate that one. We know that airborne precaution is not for this patient, for MRSA. Who would you use an airborne precaution for? What are some patients you'll use the airborne precautions for? Like your TB patients, you have your patients who have measles, you have a patient that has chicken pox, you have the patients that have varicella. Well, oh goodness. But definitely the ones with the varicella, with the open, the open lesions. So you definitely want to go ahead and get those patients in airborne. All right, and sometimes droplet. All right. A nurse gets a consult request for same-day discharge after close reduction of a risk fracture with moderate pain. What is the best step for this patient or for this nurse? A, approve discharge with oral analgesics. B, perform thorough pain assessment and evaluate home support and neurovascular status before discharge. C, deny the request, all fractures require admission. Or D, send patient to get an immediate CT scan. So a nurse gets a consult request for same-day discharge after close reduction of a wrist fracture with moderate pain. What is the best next step? A, approve discharge with oral analgesics. B, perform thorough pain assessment and evaluate home support and neurovascular status before discharge. C, deny the request. Or D, send the patient for immediate CT scan. Carousel says B, Marlene says B, which is perform thorough pain assessment and evaluate home support and neurovascular status before discharge. All right, so definitely that's the answer. So discharge decisions must include pain control, function, neurovascular status, and home safety. Holy File says C, deny the request. Why you want to deny the request, Holy File? Why you want to deny the request? Why you want to deny this request for the patient that is going home after a close reduction of the wrist? Options confuse you. Okay. All right, so let me read it over. So a nurse gets a consult request for same-day discharge after close reduction of wrist fracture with moderate pain. What's the best next step? A, approve discharge with oral analgesics. B, perform thorough pain assessment and evaluate home support and neurovascular status before discharge. C, deny request. Or D, send patient for immediate CT scan. So this patient already had, the procedure done, so you can always get a scan. I don't think it's like necessarily immediately. All right, approve discharge with analgesics. I don't know what's that. Well, definitely they're going to be on pain medication. But the best next step is to make sure you evaluate the patient appropriately so you can always get the best choice of medication, whether or not it's like a narcotic or something a little bit lighter, and just evaluate to see if the patient has home assessment, support available. Are they going to probably need like a social worker to come in and help out with certain things, or a home health aide, a nurse, things like those, all right, before discharging the patient. All right, and then from there, but denying the requests, most of the time, the fractures, they require admission. So you want to deny the request for that patient. All right. A hospital policy requires DVT prophylaxis after major lower extremity surgery. A post-op patient refuses pharmacology prophylaxis. The best nursing action is A, force medication per policy. B, document refusal and educate on the risk and the alternatives. C, remove mechanical prophylaxis instead. Or D, notify the insurance. So hospital policy requires DVT prophylaxis after major lower extremity surgery. A post-op patient refuses pharmacologic prophylaxis. What is the next best action? A, to force the medication per the policy. B, document refusal and educate on risk or the alternatives. And some of the alternatives is like the mechanical devices that, you can always give them. C is to remove mechanical prophylaxis instead. Or D, notify the insurance. So Anika says A, Carousel says B, document refusal and educate on the risk and the alternatives. All right, so definitely the patient has a right, they have, you had said B, okay, that's fine. All right, so when they talk about patient autonomy, that is something that is very important. So we have to respect the patient's decision. All right, and so you want to force that patient, even though the policy says they need to be on that. If the patient doesn't want it, then don't want it. All right. So the only thing you can always do is document and suggest to them other alternatives to help with their pain. All right. And then from there. And always make sure you're documenting that you educate regarding the risk and putting out, say, you know, the risk for bleeding, death, complication, worsening of symptoms, things like that, to make sure you have enough documentation to back up what you're saying after educating the patient. All right. Notify the insurance. I don't think you need to do that. All right. So patient autonomy is important. Educate, document, offer alternatives, and notify the provider are what you'll do for this patient. All right. For outpatient clinic scheduling, which patient should be prioritized for immediate evaluation? A, chronic lower back pain with stable neuro exam. B, new foot drop after accident 6 hours ago. C, mild lateral epicondylitis for injection. Or D, long-standing plantar fasciitis. So you have a patient in the outpatient setting that is to be scheduled. Which patient should be prioritized for immediate evaluation? Is it a chronic lower back pain with stable neuro exam? Is it B, the new foot drop after accident 6 hours ago? C, mild lateral epicondylitis for injection? Or D, long-standing plantar fasciitis? Marlene says B, the new foot drop after accident 6 hours ago. Hey, Kerry, what's up? Carousel says B. What do you say, Kerry? I know you're just jumping on. Kerry says B to Olifile. Definitely. So anything that is acute. If you look at the first option, chronic lower back pain, chronic, you know, it's still pain. And even if they say it's 10 out of 10, right about now, we acknowledge it and we document it. But out of the patients that you have here, who is at risk for complication? Is it the new foot drop that is, you know, just happened? They had a certain accident 6 hours ago. Are you concerned about that patient? Definitely. The chronic back pain can stay for a little bit because the patient has a stable neuro exam. So nothing is going on that is, you know, asking us to do something drastic right now. The mild lateral epicondylitis for injection, that will help with the pain. And the discomfort there, and the long-standing plantar fasciitis. So always just look at the words and see if it is something that is chronic or something that is acute. The ones that are chronic can wait for a little bit. They're not dying, you know, no complications that is gonna worsen their situation. So always go with the ones that are acute. So this new foot drop after accident 6 hours ago is definitely something you want to be considering to get in for evaluation now. All right. So new neurologic deficit suggests nerve compression requiring prompt assessment. So in order to save that patient's limb, you need evaluation immediately. All right, let's try to get the live up to 2,000 or let's say 3,000. Let's just get 800 taps on the live. All right, if you haven't followed us yet, please go ahead and follow on YT and on YouTube, at TikTok at ThinkNursing, one word. All right, my name is Stacy. Originally from Jamaica, while you're tapping up the screen. Originally from Jamaica, and I work as a house call nurse practitioner currently. My background is in emergency room nursing, all right? And I share a lot of content regarding nursing, travel, lifestyle. I talk about my experience with transitioning to the States here as well. All right, so join us on Tuesdays and Thursdays for our NCLEX or nursing study live at 7 p.m. and, you know, just pop in every now and again. All right, let's get the live up to 3,000. You're not going to try to do the live. Let's try to put the live up to 3,000. All right. All right, then. So, Carrie, thank you. I'm trying to get my folks over by TT here to top up the live, but I guess everybody's still sleeping. Is that so? Shem-eng doll, thank you for liking up the live. I appreciate you. BNB, welcome. Paintball, welcome, welcome, welcome. All right, let's go on to some other questions here. A nurse is preparing to irrigate a traumatic open fracture wound in the ER. The best PPE to protect from bone-borne pathogens would be A, gloves only, or blood-borne pathogens. Is it gloves only? B, gloves and mask? C, is it gown, gloves, face shield, eye shield? Or D, an N95 respirator only? You doze off and wake up. Oh my God. You tell me something boring? All right then. How much question we do? Let's finish this one and then we can ask a few questions. And then from there. So a nurse is preparing to irrigate a traumatic open fracture wound in the ER. What's the best PPE to protect from bloodborne pathogens for this patient or the nurse? A, gloves only. B, gloves and mask. C, gloves, gown, face shield, eye protection. Or D, the N95 respirator only. C, gloves, gown, face shield, eye protection. Definitely. How much will LPN get paid? I'm not so sure. In a king face, you're gonna have to go until, you can go onto chat or you can go onto Google, any one of those platforms in your state, and then try to find out those answers, like the average for LPNs and all. All right. So C. All right, nice. So C is the answer: gloves, gown, face shield. Because just think of it, you're gonna irrigate, so there's a high possibility that you will have flashes. All right, because of the force. So you definitely want to put on your eyewear. You also want to put on your gowns, your glove, and just make sure you're getting the full protection. All right, barrier protection there. So the gloves, gown, face shield will definitely help with that. As I say, anytime you see an answer that has only with the, as an option, just ignore that and just move on. Gloves and mask is okay, but you definitely need your eye shield, because as I say, if not, you'll be introducing all of those bacteria, the blood, into your face, into your eyes, and you don't want that. Or even in your mouth, and you don't want it. You understand? N95 respirator is a little bit extreme for this, but if you want to wear it, you wear it. You understand? But it's not suitable for this. You don't need an N95 for this. All right. A sterile orthopedic case requires implant handling. Which action breaches sterility? A, scrub nurse uses the sterile forceps to pass the implant. B, circulating nurse opens the package and drops the implant into the sterile field without sterile gloves. C, surgeon requests final implant size. Or D, sterile instrument tray placed at the edge of the field. So you have a sterile orthopedic case that requires implant handling. Which action breaches sterility? A, the scrub nurse uses the sterile forceps to pass the implant. B, circulating nurse opens package and drops implant into sterile field without sterile gloves. C, surgeon requests final implant size. Or D, sterile instrument placed at the edge of the field. All right, so which of these would breach sterility for this patient? Hi Shane, how are you? D, so sterile instrument placed at the edge of the field. Everything Anika is saying. Do we have anybody else? Kerry says C, the surgeon requests final implant size. Then she changed and says D. Okay, nice. See us, Ellis. Do you have anybody else? Carousel, please wake up. Wake up, wake up, wake up. All right, so remember, so you're trying to find out which option here breaches sterility of that field. So is it A, the scrub nurse uses a sterile forceps to pass the implant? Did she breach anything there? She is a scrub nurse. She's using the sterile forceps to pass the implant to the surgeon. Did she breach anything there? No. Is it B? Let's go on to C. The surgeon requests final implant. So the doctor say, hey, can I get the final implant? He didn't add anything to say that he, held out his hand and get the implant or anything like that. So we're going to mark that one off as well. Sterile instrument placed at the edge of the field. We know that with the sterile kit, there is a certain amount of inches that you definitely have to have your sterile field in. So I don't remember the exact amount of inches. It has to be away from the edge of the field. But remember, this one in B says the circulating nurse opens the package and drops the implant into the sterile field without sterile gloves. So which action breaches sterility there? Is it that one? Oh. So the sterile instrument placed at the edge of the field. The circulating nurse opens the package and drops the implant into the field without the sterile glove, That's the one that breaches. All right, I think we kind of did. I was getting this question confused. So a sterile orthopedic case requires implant handling. Which action breaches sterility? So which one of them mess up the sterile field? All right. Is it A, the scrub nurse uses the sterile forceps to pass the implant? That seemed like it's okay to me. What do you think? The correct answer is actually B. The circulating nurse opens the package. I guess we need to know the role of the scrub nurse and the circulating nurse, right? So the circulating nurse opens the package and drops the implant into the sterile field without sterile gloves. But I'm thinking that if it's a sterile package, if you have a package and you open it and drop it on the field, would she breach anything there? Would she have breached anything there? I don't know. The surgeon requests final implant size. That's not a breach. Sterile instrument placed at the edge of the field, depending on the... So if she drops without touching it, it does not contaminate the field. That's what I'm thinking, Claudette, as well. So it says the circus. I guess we need to understand the role of the circulating nurse and the scrub nurse. But either way, anybody in the room can actually take up something. And once you maintain sterility, you don't touch the inside of that, package. Even if you're not wearing a glove, I'm thinking that it's okay. Because we do it all the time. You're in a rush and probably somebody's doing something and you take up your package and you open and you drop on the sterile field. So why is it saying that B is the answer? Okay, so it says dropping an implant from an ungloved hands breaches sterility. So I guess I need a sterile glove to take up the package and then open it. Well, this is America. This is NCLEX. So I'm confused as well because the circulating nurse doesn't need to be sterile. Exactly. So that's what I was wondering. So it says dropping an implant from an ungloved hand breaches sterility. So I guess everybody in the room needs to be in a sterile glove. A sterile orthopedic case requires implant handling. Which action breaches sterility? So it says that the circulating nurse opens a package and drops the implant into the sterile field without sterile gloves. Well, that's the answer they say. But as I say, usually anybody in the room, if you're available, I think you should be able to open the package. And once you're maintaining, the little thing that you do, whatever, and you drop it. So even if you're not wearing your sterile glove and you take up that package, did she open and pick the implant before dropping? So, Carousel, that's a good question. But the question only says... Okay, I guess based on the question, it says a sterile orthopedic case requires implant handling. Circulating is not sterile. Yeah, circulating is not sterile, but I guess, yeah, circulating is not sterile. The scrub nurse is. The circulating nurse is not sterile. So I guess they're okay. So this is the real world. This is the NCLEX world. This is the real world, okay? So if you're not the circulating nurse, you're not supposed to be over there. So I guess, I don't know. But dropping an implant from an ungloved hands breaches sterility. So I guess the scrub nurse is supposed to be doing all of that handling. All right, and nobody else, okay? That's all I'm thinking. I don't know, but I guess everybody's thinking the same thing I am thinking with, the fact that you have persons who might not be the circulating nurse or the scrub nurse that might be busy doing something and the doctor needs something and you probably just go ahead. And once you're maintaining sterility, not touching the inside of the package, then, we're thinking that it's okay. But based on this question, it says dropping an implant from an ungloved hand breaches sterility. All right, so we need to just look at that. Need to go and get a bath. All right. During traction care, Fire, welcome, welcome, welcome. During traction care, the nurse notes the pin site has 1 centimeter area of erythema, but no drainage present. What's the best action? So during traction care, the nurse noticed that there is a pin site that has a 1 centimeter area of erythema, but no drainage. What is the best nursing action? A, remove the pin. B, continue standard pin care and monitor. Document the findings and notify the provider if worsening or purulent drainage appears. C, immediately start IV antibiotics. Or D, tighten the traction weights. So you have a patient that has a traction and you're doing the traction care. You notice that the pin site has 1 centimeter area of erythema or redness, but there is no drainage. What is the best nursing action? Is it A, remove the pin, B, continue standard pin care and monitor, document your findings and notify the provider if it is worsening or if you notice there is any purulent discharge, C, immediately start the IV, all right, antibiotics, or D, tighten the traction weights? What would you do at that time? So Claudette says B, Kerry says B. All right. Holy File says B. Okay. So definitely, when you have like minor erythema, it can be just something that is inflammatory. All right. So just monitor it, and then from there, if you notice that there is any sign of infection, so if it becomes purulent or you see pus, you understand? Then definitely, or if the patient starts having fever, definitely you want to go ahead and make sure that the doctor, start doing something about it. All right. But you don't need to escalate it like, drastically by starting antibiotics and all of those things, because the mere fact that you have the pins there, there is going to be some form of redness there. But you're more concerned whenever it starts gathering like pus or it becomes purulent. You're thinking that it's infected. All right. So you'll just continue with the standard pin care and monitor. You document the findings, notify the provider if you notice that it's getting worse. All right, and from there, escalate if the infection signs worsen, monitor and maintain a pin care. All right, so if it is mild or minor inflammatory changes, then that is something for you to observe. You don't need to start antibiotics for that. We understand that it is, the traction is there and you're thinking about the bone infection and everything. But as I say, if it is not having that purulent discharge, if it is mild, then you can always just observe, clean properly, make sure you're cleaning in those pin sites well, and then from there. All right, immediately start IV antibiotics now. All right, tighten the traction weights or remove the pin. Definitely you don't want to do neither of the two. All right, call the orthopedist and let them come and do their thing if that's the case. All right. A patient scheduled for joint replacement reports a dental abscess. The nurse should A, proceed with the surgery, all right, because the dental issue is not related to, the surgery. B, alert the surgical team. C, prescribe prophylactic antibiotic and proceed. Or D, refer to psychiatry for anxiety. So you have a patient who has a joint replacement that is scheduled, and the patient reports that they're having dental abscess. The nurse should A, proceed with the surgery because the dental issue and the surgery is not related. Is it B, alert the surgical team? C, prescribe prophylactic antibiotics and just proceed? Or D, refer the patient to psychiatry for anxiety? What would you do? B, okay. All right. B, all right. So because the patient has an active infection, the patient has that dental abscess, you want that to get sorted out because remember the patient is going to get joint or knee replacement, all right? So you definitely want to go ahead and make sure you clear up any form of infection because you don't want to risk that area, the joint, the prosthetic limb that the patient will be getting. You don't want that to get infection, all right? Because that's a high risk for infection there as well. So you want to make sure you clear up any other infection, any site that has infection before you think about proceeding with that surgery. All right, so active infections, the dental abscess increases the risk of prosthetic infection, joint infection. So treat before elective arthroplasty. All right, refer the patient for psychiatry evaluation because of anxiety. I don't know why they would put that there. Prescribe prophylactic antibiotics and proceed. Definitely the patient will eventually be getting some prophylactic antibiotic. You understand? But proceeding with the surgery because the dental is related, is not related, no. You want to go ahead, clear up that infection, that dental infection, and then from there, you proceed with your surgery. All right? A nurse finds a contaminated sharps container overfilled. What's the best, the immediate step for this nurse? A, to tape the lid closed and continue. B, report and replace the container per the policy. Do not attempt to push the sharps down. C, push down sharps to make room for more. Or D, leave it because housekeeping will handle it. So what's the best option? So you notice that you're in the nursing station or you're on the floor and you realize that the sharps container is filled. It's overflowing. All right. What is your best nursing action? A, tape the lid closed and continue. Report and replace the container per the policy. C, push the sharps down to make room for more because you have that one little needle that you need to put in there. Or D, you leave it alone because housekeeping will come and change it. Which is the best answer, the most suitable answer there? Carrie says B, report and replace the container per policy. Do we have anybody else? Holy File says B, nice. Do we have anybody else? Hi, Angela. Angela, welcome. How are you doing? All right, so definitely you want to go ahead and report and replace it per policy. All right, you definitely don't want to tape down anything because you're putting yourself at risk for needle stick injury. All right, push down the sharps to make more room is a no. Usually you don't even fill it up to the top because it's always like 85-90% of it, you know, is usually that's where the marker is. So it gives you ample, you know, adequate amount of room or time to say, okay, then you can get, you know, a new container. But at least when you fill it up to that level, you have the ability to close it properly. So nothing is like, you know, pushing out. That poses a risk not only to you, but to the persons that are emptying. So you want it to make sure that it closes properly. So there is probably like 80, 85, 90 thereabout percentage. There's a marker that you should fill it up to, and then you always call and get it changed out. All right, leave it, housekeeping will handle it. You know, usually you leave it there, but you call whoever needs to get it switched out, and then from there. All right, so overfill containers increases the risk for needle stick injury. Follow the policy and replace it safely and report. All right. All right. So you have a patient that is going in for surgery. Which perioperative glucose value in this diabetic patient indicates increased risk for infection and should prompt intervention before elective joint replacement? So you have a patient that is diabetic. The patient is going in for surgery. All right. But the patient is at increased risk for infection. Which intervention is important before this elective joint replacement? Is it getting the glucose? Is it the fasting glucose that is 90? All right. Which perioperative glucose value in the diabetic patient indicates higher risk or increased risk for infection and should prompt intervention before elective joint replacement? Is it A, the fasting glucose of 90? B, the random glucose of 160? C, the hemoglobin A1C of 9.2%? Or D, the postprandial glucose of 130 milligrams? So which perioperative glucose value in a diabetic patient indicates increased risk for infection and should prompt intervention before elective joint replacement? Is it A, the fasting glucose of 90? B, the random glucose of 160? Is it C, the hemoglobin A1C that is 9.2? or D, the postprandial glucose, that is 130. So which one is gonna be indicative of, you know, increased risk for infection for this patient? C, which is the hemoglobin A1C of 9.2%. Okay, Anika, do we have anybody else? What about Kerry, Claudette? Which one do you say? Or Carousel? Sorry, Ann? Get off my bike. Sim, welcome, welcome. Which one did we say? All right, Carrie says C, the hemoglobin A1C of 9.2. What number is a good score for your A1C? What's it like, you know, normal A1C? What are you looking for? What's a good A1C score? Anything below like 5.9? Anything below 5.9? All right, so for your A1C, anything that is greater than 8%, under 6%, definitely. All right, so anything that is A1C of greater than 8% correlates with poor glycemic control and is at higher risk for infection. All right, so you always want to make sure you get that number down before you go ahead and try to get your patient in for surgery. All right, so the fasting glucose of 90, you know, that's okay. The random is okay. Postprandial is okay, but the hemoglobin 9.2 is very high. So you have to get that control and then from there. All right. Which findings suggest compartmental syndrome is developing in a leg after fracture? So a patient that has pain controlled with opioids, A. B, increase in pain with passive stretch and tense swelling. C, slight ecchymosis. D, decreased sensation only at the toes but with strong distal pulse. So which findings suggest compartment syndrome developing in a leg after surgery or after fracture? A, pain that is controlled with opioids. B, increase in pain with passive stretch and tense swelling. C, slight ecchymosis. D, decreased sensation only at toes but with strong distal pulses. So B, increased pain with passive strength, stretch and tense swelling. Do we have anybody else? Another answer, another option? And we know that what's compartmental syndrome or compartment syndrome? So a lot of times you have these patients reporting pain that is very, very excessive, right? So even when you're giving them their narcotics, a lot of times they tend to have a lot of pain. So the pain is so, especially, you know, your patient that are in their plaster of Paris, they have the cast on. A lot of times they tend to be having a lot of pain. And regardless of you giving them pain medication, because of that pressure in the leg, they tend to be having a lot of pain. So you need to, release that pressure in that, that limb, because it's not only in the leg, but you need to relieve that pressure in the limb, and then from there, hopefully the pressure will go down. All right. So the increased pain with passive stretch and tense swelling is definitely signs that suggest that the patient is developing compartment syndrome in that leg. All right. So pain with passive stretch and tense swelling are early signs of compartment surgery syndrome that needs emergent fasciotomy. All right. Slight ecchymosis is usually pretty present most of the time, when you have any form of fracture. Decreased sensation only at the toes, but with strong distal pulse. You still keep an eye on that. All right. Pain with control, that is controlled with opioids, is pretty common. All right. You might have the patient having pain. You give them the narcotics. It helps with the pain. That is pretty good. All right. All right, let's try to get this live up to 3,000 people. Live shines, welcome. Black Queen, thank you so much for tuning in. All right, let's try to see if we can tap up the screen a little bit. All right. Let's try to tap up the screen a little bit, folks. Where is my moderators? None of them not on the live here, not one. All right, Pillow, welcome, welcome, welcome. All right, let's continue. What time is it? 8 o'clock, 8:15. All right. So a patient on chronic NSAIDs asks about GI prophylaxis. What's the best preventative strategy for this patient? We know that NSAIDs tend to cause a lot of bleeding, like, put the patient at risk for GI bleed. So you want to make sure that this patient is on some GI prophylaxis. What is going to be the best preventative strategy for this patient? Is it A, to add a proton pump inhibitor for your protection? B, reduce protein intake? C, stop all medications immediately? Or D, use enteric-coated aspirin? So what's the best preventative strategy for this patient? What is the best thing you can do for this patient to protect the stomach? Liveshine says A, which is, and Anika says A, to add a proton pump inhibitor for GI protection. What's an example of a proton pump inhibitor or a PPI? What are some of the common ones we know of? What are some of the common PPIs that we know of? Pantoprazole, lansoprazole, omeprazole. All right, definitely. Dexium, Ines, yes. All right, so all of those are things that we will use. Reduce protein intake is not, yeah, we're not really concerned about that. Stop all medications, no. Use enteric-coated aspirin. Anyway you take it is aspirin, so the patient is going to be at risk for bleeding as well. So definitely you would want to go with your PPIs, because those are going to help that with reducing those GI ulcer. All right, so the patient is going to be at high risk for ulcer, so you want to make sure you give something to protect the stomach lining. All right. Which vaccine is recommended for adults who have had a splenectomy to reduce infection risk that may complicate musculoskeletal infections? So you have a patient that has their spleen removed. All right. Which vaccine is recommended for that person to reduce infection risk that may complicate musculoskeletal infection? A, influenza only. B, meningococcal, pneumococcal, the Ib vaccine, which is the Haemophilus influenza type B vaccine. Or is it C, HPV vaccine only? Or D, they don't need any additional vaccine? So you have a patient that has had their spleen removed. They have had splenectomy, but they need a vaccine because they're at high risk for infection, because they're going to be doing a musculoskeletal surgery. All right, and you don't want any complication. Which of the vaccine would you recommend for that person? Is it A, the influenza only, B, meningococcal, pneumococcal, Haemophilus influenza type B vaccine? Is it C, the HPV vaccine only, or D, they won't get any vaccine or don't need any vaccine? Carousel says B, which is meningococcal, pneumococcal, all of those. Carrie says B. Okay, nice, nice. All right. So asplenic patients needs broader immunization, including the pneumococcal, the meningococcal, and the hib vaccine. All right. As I said, the flu vaccine, the HPV vaccine, you always still recommend all of those vaccines to your patient. But because, as I say, when you're doing the NCLEX, always try to avoid anything that says only, influenza only, HPV only, you know, because there are other things that they need as well. All right. And if you see the option that says nothing at all, don't do anything, no, that's not the answer. Because for the exam, you're required to do something. All right. So that's it. Hold on 1 minute. Leave that for me, please. Put it up here. All right. Let me go down to some of these pharmacology questions. Which analgesic is contraindicated in patients with severe renal impairment for post-op pain? All right. Hi. How are you doing? So which analgesic is contraindicated in a patient with severe renal impairment for post-op pain? A, acetaminophen. B, NSAIDs. C, low-dose morphine and monitoring. D, local infiltration analgesia. So which analgesic is contraindicated in a patient with severe renal impairment for post-op pain? Is it A, your acetaminophen, B, your NSAIDs, C, your low-dose morphine with monitoring, or D, local infiltration analgesia? Which one is contraindicated in your severe renal patient? So Carrie says B. Do we have anybody else? Leona Bryce, welcome. All right, so definitely the answer is B. All right, always remember that your NSAIDs, they affect your renal function, so they're always going to be, you know, contraindicated with your renal patient. Your patient can always get Tylenol, but also, you know, not necessarily for renal impairment issue you're concerned about. But always remember that the liver, you understand, for your patients with your Tylenol. Low-dose morphine, it should be fine. Local infiltration should be fine, depending on what's going on with the patient. All right. So which analgesic is contraindicated in a patient with severe renal impairment for post-op pain is going to be your NSAIDs. All right. So anything like your Toradol, your Ketorolac, your Aleve, ibuprofen, Motrin, things like those are going to be contraindicated. All right. Because they worsen the renal function for these patients. A patient with gout is started on allopurinol. What is the best nursing education point for this patient? So you have a patient that is on gout and the patient is getting allopurinol for pain. What's the best nursing intervention or nursing education point for this patient? A, continue during acute gout flare. B, stop allopurinol at first sign of a flare. C, allopurinol treats pain in flares immediately. Or D, start and stop therapy as needed. Thank you for the heart me life shines. All right. So you have a patient that is on allopurinol, but the patient has a history of gout. So the patient was recently started on that. What's the best nursing education point? A, to continue during acute gout flare. All right. B, stop allopurinol at first sign of flare. C, allopurinol treats pain in flares immediately. Or D, start and stop therapy as needed. So Kerry says A, which is continue during gout flare. Do we have anybody else? Thank you, Elaine, for joining. Do we have anybody else? Okay. All right. So definitely you want to go ahead and encourage them or let them know that allopurinol is a medication that should be continued. Initial therapy can trigger flares, so prophylaxis is common. What is one of the other medications that they tend to use for your gout patients? What other medications are normally used for gout? Your colchicine, you know that one. So they normally use that one for your initial precipitation or your initial flare-up. All right. So you got colchicine, and then they will usually do like your allopurinol for your maintenance or long-term use. All right. So allopurinol is a urate lowering therapy and should be continued. All right. So A is the one that you'll tell them continue during acute gout flare. Initial use may precipitate flares. So you have colchicine or NSAID prophylaxis that might be given initially. All right. Hi, Robbie. Good night. All right. A patient receives intraoperative tranexamine acid, TXA, during TKA. The primary nursing rationale for its use is, what is TXA used for? Tranexamine acid. TXA, what is it used for most of the time? To stop bleeding. Definitely. So a patient received intraoperative TXA during total knee replacement surgery. The primary nursing rationale for its use is to A, reduce surgical blood loss and the need for transfusion. B, provide analgesia. C, prolong anesthesia. Or D, increase infection risk intentionally. So it is used to decrease your bleeding, reduce your bleeding, stop your bleeding during procedures. All right, especially in your orthopedic cases. All right. A patient on warfarin is scheduled for elective spine surgery. Pre-op INR goal should be A, within therapeutic range for surgery, which is typically what? Less than 1.5. All right. B, INR, which is greater than 3. C, no need to change warfarin. Or D, double the warfarin dose. So you have a patient on warfarin that is scheduled for elective spine surgery. Pre-op INR goal should be A, within therapeutic range for surgery. B, INR greater than 3. C, no need to change the warfarin. Or D, double the warfarin dose. What's your answer? So you have a patient that is on warfarin and the patient is scheduled for elective spine surgery. The pre-op INR goal should be A, within the therapeutic range for surgery, which is less than 1.5. B, INR greater than 3. C, no need to change the warfarin dose. Or D, double the warfarin dose. The option is going to be what? So it's going to be A, you want it to be less than 1.5. All right. So you want it to be at the therapeutic range of less than 1.5 for your patient. All right. Warfarin is usually held and reversed per protocol if it is like, too high. All right. If you give too much. So Kerry says C, no need to change the warfarin. Okay. So if the patient is scheduled, so the goal for the INR is going to be less than 1.5. Option C says no need to change the warfarin. All right, so for elective surgery, anticoagulation is adjusted to reduce bleeding risk. Reversal may be needed. So they might just give something to help with reversing, so the patient is not bleeding too much when they go into surgery. All right. Oh, everything, Anika. Sorry, I didn't see your answer earlier. All right. So the answer is A. So you have the patient on warfarin that is in for elective spine surgery. Pre-op INR goal should be within the therapeutic range, which is less than the 1.5. All right. So anything that is greater than 3 for your INR is too high. So that is, putting the patient more at risk of bleeding. No need to change the warfarin or double the warfarin dose. We're not going to double up on any warfarin dose. All right. So for the elective surgery, anticoagulation is adjusted to reduce bleeding risk. All right. All right, I'm going to do a few more questions. Let's say, try to do about, what time, 8:30. I have so much notes that I need to go and do. All right. Which electrolyte abnormality is most commonly associated with rhabdomyolysis and can be life-threatening? Is it A, hyperkalemia from muscle cell breakdown, B, hypokalemia only, C, hypernatremia only, D, hypocalcemia only? So which electrolyte abnormality is most commonly associated with rhabdomyolysis and can be life-threatening? Is it A, hyperkalemia from muscle cell breakdown, B, hypokalemia only, C, hypernatremia only, or D, hypocalcemia only? A, hyperkalemia from muscle cell breakdown. Carousel says yes, Kerry. Definitely hyperkalemia from muscle cell breakdown. So rhabdomyolysis releases intracellular potassium, risking arrhythmias. Immediate monitoring and treatment is required. And one thing that is important for this patient is what? Apart from your cardiac monitor and everything, what else is very good for this patient? Cardiac arrhythmias, definitely. What else is very good for this patient? Because this patient is going to be at risk for kidney injury and all. What else is very good for this patient? Would you give a lot of fluids to this patient or not? Or kind of hold off on it? Want to make sure you give this patient a lot of fluids. All right, so this patient is going to need a lot of fluids there to help with preventing any kidney problems. Sodium. Huh? Kidney injury. Yeah. Everything, Anika. What about the sodium? All right, so you definitely want to give a lot of fluids for this patient, to this patient. All right, IV fluids, definitely. The other options, as I say, anytime you see hypokalemia, not hypokalemia, but anything that you see with only as the option, that's always a no-no. All right, because, well, hypokalemia only, the patient is going to be hyper. All right, hypernatremia only, as I say, always think of this, omit the only. The options that has only there. All right. Hypocalcemia. Would this patient be hypocalcemic? Would this patient be hypocalcemic when they have rhabdo? So let's look up that. Well, let's see. Rhabdomyolysis and electrolyte imbalances. All right. So this patient would have hypocalcemia, hypercalcemia, hyperphosphatemia, and sometimes hyponatremia. All right. So definitely, so hypocalcemia, hypercalcemia, and hyponatremia for this patient with rhabdo. All right. So you can also look out for confusion for these patients, all right? Depending on what's going on. All right. A patient with SLE, systemic lupus erythematosus. SLE presents with inflammatory myopathy causing proximal muscle weakness. Which lab is most useful to monitor disease activity? So you have a patient with systemic lupus erythematosus, SLE, that presents with inflammatory myopathy causing proximal muscle weakness. Which lab is most useful to monitor disease activity? A. Creatinine kinase levels and aldolase. B. Random glucose only. C. AST only. Or D. Hemoglobin A1C. So which lab is most useful to monitor the disease activity? Is it A, creatinine kinase and the aldolase, B, random glucose only, C, AST only, or D, hemoglobin A1C? So Carrie says A. Okay, do we have anyone else that has another option? Everything. Anita says A. Definitely your CK and aldonase are used whenever you have any form of inflammation, any muscle inflammation, necrosis, or any myopathies or anything like that. All right. Your hemoglobin A1C usually tells, like, with a diabetic patient, so good or how bad their diabetes is. AST is one of your liver enzyme. All right. And the random glucose, we use it for basically everybody. All right. Okie dokie. Gonna do one more question. And then from there, let's see. Okay, let's see. One more question. The most reliable sign of DVT in a post-op orthopedic patient. So the most reliable sign of DVT, deep venous thrombosis, in a post-operative patient, orthopedic patient, is A, unilateral limb swelling and pain with calf tenderness and erythema. B, bilateral leg itching. C, mild systemic edema, or mild symmetric edema, or D, bruising only. So what's the most reliable sign of a DVT or deep venous thrombosis in a post-op orthopedic patient? A, unilateral limb swelling and pain with calf tenderness and erythema. B, bilateral leg itching. C, mild symmetric edema, or D, bruising only. Carousel says A. Carrie says A. Okay. Yes, the unilateral limb swelling and pain with calf tenderness and erythema. That is usually suggestive. This unilateral swelling, the calf tenderness, the redness, the warmth usually indicates DVT. And how do you go about with confirming or testing? What diagnostic test can you use to tell whether or not you have a clot on board for DVT? How would you go about with that? Hi, Forever Bless, how are you? How would you go about with checking for this patient? If you want to know if there's a clot on board, how would you go about with checking? Good. All right, what test can we do for this patient? Say good. Your Doppler ultrasound, okay? You can also get a D-dimer, but your Doppler ultrasound is the one that is going to confirm whether or not you have your clot. You have a DVT down that side, all right? So unilateral swelling, pain with tenderness suggests DVT. Diagnostic testing include your D-dimer, your ultrasound as follow. All right, so if you notice any of your patient having this, try to get your ultrasound done, and then from there, see if there's any clot. All right. All righty. Well, this was the musculoskeletal. I have about I have a few more questions, but as I say, I'm trying to work with the time. So I have a lot of charts to do. So I'm gonna actually end the live right now. And then I will see you guys when, next week or tomorrow? Well, I'm doing exercise tomorrow at 5:30. But in terms of the nursing live questions, we'll try to do that on Tuesdays and Thursdays. So definitely I'll see you guys next week, Tuesday. But I'll see you tomorrow for my exercise session. All right. So until then, thank you so much. If you haven't followed us, go ahead and follow. If you're joining in late, you can always find the video or the live over by the YT page. All right, the full live stream are over there. And then from there, you can always ask them questions. You can send suggestions as well as to what you want us to kind of prepare in terms of questions, and then from there. All right. Not a problem, Carrie. Thank you as usual for always showing up. Thank you, everything, Anika. Forever blessed, Lydia. Where is Sleepy Carousel? Carousel. Thank you so much for always being here. All right. One mysterious. I think I'll be doing something on the live. So I'll be up, but I'm doing something on the live with someone. All right. But I'm going to end the live and then do what I'm going to be doing shortly as well. Robbie, thank you so much for passing by. Okay, no problem, Anika. Usually we go a little bit longer, honestly, on a Thursday. But I have so much things on my mind right now. All right, I have so much things on my mind going through. And plus I have my notes and everything. So I'm going to try to get some of those out of the way before tomorrow. All right, before tomorrow. So that way next week we can still do our 2-hour class and probably on Friday a little bit longer. No, you're fine, Robbie. Not a problem. Thank you so much for showing up. All right. Thank you so much for... Yes. As I say, a whole lot of stuff I have to do. A lot of things I have to do. So I'm only doing from 7 until 8:30 today. All right. And then from there. But we will catch up. You know, on Tuesday, we'll probably end up doing 2 or 3 hours. You know, so I'm sorry for tonight. As I say, you know, we didn't get a chance to complete all of the questions, but there are other days we'll do more questions. All right. So thank you so much for tuning in, and I will see you. All right. No problem, Carousel. I'll see you in a bit. All right. Bye.